part of the or other specialties, and the information provided by this imaging technique can modify the management of patients. For more information about this webinar, please visit the webinar listing in the AIUM Education Center on our website. During this presentation, if you have questions for the presenter, you may enter them into the Q&A box on the bottom of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. I will now launch the pre-recorded webinar, Top Applications of Dermatologic Ultrasound.
Hello everybody. It's my pleasure today to share this lecture with the top applications of dermatological ultrasound. Well, first, we will talk something about the anatomical implications, and then we will move to the main applications of ultrasound. So, what are the anatomical implications? First,
I apologize, everyone. Please bear with me one moment.
hello everybody. It is my pleasure today to share this lecture with the top applications of dermatologic ultrasound. Well, first, we will talk something about the anatomical implications, and then we will move to the main applications of ultrasound. So, what are the anatomical implications? First, how does the skin look on ultrasound? If you look your image on the left, you will see the ultrasound of the skin in the dorsal forearm using an 18 MHz probe. On top, you can see the epidermis that appears as an hyperechoic line, and the echogenicity of the epidermis is provided by the keratin content. Then you see the dermis, and the dermis appears as an hyperechoic band, less bright than the epidermis, and the echogenicity of the dermis is provided by the collagen content. Then at the bottom, you can see the hypodermis, and the echogenicity of the hypodermis, which is mainly hypoechoic, is provided by the fatty tissue. In between the fatty lobules, you can see hyperechoic septa that are composed by the fibrous septa of the subcutaneous tissue. On the right, you can see the exquisite anatomy when you move up to 70 MHz. Please note that here you can see on top an hypoechoic band in the dermis that corresponds to a hair follicle. And beside the hair follicle, you can see this ovoid structure, hyperechoic, that corresponds to a sebaceous gland. Then at the bottom, you can notice this hyperechoic bilaminar structure that corresponds to the hair tract before going into the surface. So this anatomy is very similar to the anatomy that we see on histology. If we compare the resolution of ultrasound with computed tomography and magnetic resonance imaging, the axial spatial resolution of ultrasound is much higher. Please note that if you try to look for the epidermis and dermis in the computed tomography, it's impossible. And the same thing on MRI. You can notice something of the hypodermis, but that's it. How the nail looks on ultrasound. You can see some images of the index finger in longitudinal view, and you can notice on top a bilaminar structure, hyperechoic, that corresponds to the nail plate. The nail plate has two parts, one superficial that is called the dorsal plate, and then one inner plate that is called the ventral plate. Then underneath the nail plate, you have an hypoechoic area that corresponds to the nail bed. In the proximal part of the nail bed, we have the matrix region. And on top of that, you can see the dermis and epidermis of the proximal nail foot, which is the periungual area. At the bottom, you can notice an hyperechoic band that corresponds to the bony margin of the distal phalanx. With the new machines, you can make nice power angio reconstructions in three-dimensional views of the nail. If you go up to 70 MHz, you can see a zoom of the nail with a much more clear image of the nail plate and the nail bed. What are the requisites for performing dermatologic ultrasound examinations? First, you need a proper equipment, and this equipment should have a color Doppler ultrasound machine with a multi-frequency probe that could go up to equal or higher to 15 MHz. In the market, we have several options now. You can see some of them in the screen. So it is really possible to see with good resolution the skin, the nail, and the hair. The second requisite is a trained operator in ultrasound and dermatologic conditions. Fortunately, we have now a lot of information in the literature, and there are courses on dermatologic ultrasound that are sponsored or under the umbrella of different scientific organizations, and AIUM is one of these scientific organizations. The other thing that we need to know are the limitations of dermatologic ultrasound. And these include, if you're using 18 MHz, the lesions that measure less than 0.1 millimeter, and if you're using a 70 MHz probe, the lesions that measure less than. Other limitations are the lesions that are epidermal only and the detection of pigments. Importantly, we have now guidelines in the literature for performing these dermatologic ultrasound examinations. We have one of them published in the Journal of Ultrasound in Medicine and another in the Journal of the European Federation of Societies for Ultrasound Medicine and Biology. These two articles put some quality standards on the performance of the examinations, which is important to the accreditation of the quality of the examinations. So, what are the applications of dermatological ultrasound? We can divide in several applications, such as benign tumors and pseudotumors, vascular lesions, skin cancer, inflammatory dermatologic conditions, aesthetics, and nail lesions. We are going to begin with benign tumors and pseudotumors, and we will divide these lesions in cystic and solid. First, the cystic. I would say that one of the top requests of dermatologic ultrasound is epidermal cyst. And this is a lesion that is caused by remnants of epidermal components embedded into the dermis. This epidermal cyst, also called infundibular cyst, are lined by squamous stratified epithelium and present a granular layer on histology. They contain keratin, and the term sebaceous cyst is a misnomer because the lesion does not present sebaceous glands or sebaceous components. On ultrasound, this lesion appears as an oval or round shape, anechoic or hypoechoic structure that generates a posterior acoustic enhancement. It could be partially or totally compressible and usually doesn't present vascularity. You can see in the clinical image the lump that is produced by this epidermal cyst, and then you can notice the hypoechoic structure in the subcutaneous tissue protruding into the dermis with some hyperechoic lines that corresponds to PAC keratin. This is the appearance of an intact epidermal cyst. But this epidermal cyst, and this is the problem, become inflamed, and then they could rupture and spread the keratin into the neighboring tissues. So the appearance can change. And as you see here, this oval or round-shaped structure becomes an ill-defined structure. Lesions is the presence of this posterior enhancement artifact. The epidermal cyst has a capsule, and when the cyst becomes ruptured and these remnants of capsule remain in the tissues, the epidermal cyst has a high probability to reproduce. The only way to look for the capsule is to have a higher frequency, an ultra high frequency such as 70 megahertz. As you see here, the capsule is very thin and hypoechoic and surrounds the cyst. This is a case of a partially ruptured epidermal cyst. You can notice the clinical lesion. And then on your right, you can see that the borders becomes ill-defined, especially in the border on your left. Also, you can notice the communication of the cyst to the subepidermal region that is called punctum. This punctum can be observed in some cases, but not in all the cases. If you add color Doppler to the epidermal cyst, in this case, you will see an increased vascularity in the periphery of the cyst due to the inflammation. Please note the posterior acoustic enhancement at the bottom of the cyst. Then we can see the totally ruptured epidermal cyst. And in this case, you can notice that there's no well-defined structure. There is hypoechoic tissue in the dermis, still with some posterior acoustic enhancement. And please see the hypervascularity, mainly in the periphery of the structure. But if we go to the 70 MHz probe, we notice fragments of the capsule in the dermis. Another cystic structure that is possible to see is the tricholemal cyst. This is a cyst derived from the external sheath of the hair follicle. Histologically, the difference with the epidermal cyst is that the tricholemal cyst doesn't present a granular layer. On ultrasound, we see that most of these lesions present similar appearance of an epidermal cyst, but the location is different, and most of these lesions are located in the scalp, as you see here in the clinical case. Notice that in this case the lesion is hypoechoic, oval-shaped, and present echoes inside with posterior acoustic enhancement and some hypervascularity in the periphery due to the inflammation. Another cystic structure is Pylonidal cyst, and this is not really a cyst. This is a pseudocyst or a cavity that is produced by inflammation and granulation tissue. This cyst can present as a sac-like or van-like hypoechoic structure. The location is usually the intergluteal region, and that is very common. And notice that within the cyst that is running through the dermis and hypodermis, you can see some hyperechoic lines that corresponds to fragments of hair tract. On color Doppler, you can notice the hypervascularity due to the inflammation. In a study that was published in the Journal of Ultrasound in Medicine in the year 2017 by our team, we noticed that the presentation of the pylonidal cyst is very similar to an inflammatory autoimmune disease called hidradenitis suppurativa. They contain similar morphologies like the dilation of the hair follicles, the communication of the lesion to the dilated base of the hair follicles, and these sac-like or van-like structures with fragments of hair tracts within the lesion. The second part of the benign tumors and pseudotumors are the solid ones. The pilomatrixoma is one of the most common. This is a benign tumor derived from the hair matrix. It is important to perform an ultrasound here because the clinical diagnosis in pilomatrixomas has a high rate of error, which is published in the literature, and this error goes up to 56%. The most common clinical lesion is a bump, which is very similar to epidermal cyst. It can show erythema as well. And on ultrasound, the most common form of presentation is the target type that appears as a round or oval-shaped nodule located in the dermis and hypodermis with an hypoechoic rim and an hyperechoic or heterogeneous center. In the center of the lesion, you can notice some hyperechoic spots that corresponds to calcium deposits. On color Doppler, you can notice hypervascularity within the lesion. Some of these pilomatrixomas can be very vascular, and present clinically a differential diagnosis with hemangiomas, but other pilomatrixomas can be hypovascular, so they are very variable in their vascularity. The key point to diagnose pilomatrixomas is the presence of calcium, and the level of calcium is also variable because some of these lesions can present low presence of calcium and others could be completely calcified. This is a case. You can see the clinical lesion on your left, and on your right you can see the target type of lesion with hypoechoic border, an heterogeneous center, an hyperechoic spot that is marked with an arrow, and intermediate degree of vascularity. If we go to a 70 MHz probe, you can notice the multiple hyperechoic spots with posterior acoustic shadowing artifact that are a typical finding in pilomatrixoma. Another solid lesion that could go to your office or clinic is the lipoma. One of the most common forms of presentation of lipoma is the Fibro Lipoma. This is a tumor that contains a mix of mature adipose cells with fibrous components, and lipomas are one of the most common soft tissue masses. On ultrasound, you can see an oval-shaped hypoechoic structure located in the subcutaneous tissue. In between this fatty tissue, you can notice the hyperechoic septa that correspond to the fibrous septa. Also notice that this lesion goes into the same axis of the skin layers. On ultrasound, they present a low degree of vascularity, usually with some peripheral vessels and some inner vessels. When you have an heterogeneous fibrolipoma or an hypervascular fibrolipoma, you must suspect a malignant transformation. When the mature adipose cells are mixed with capillary cells, then we have a variant of lipoma that is called Angio Lipoma. In this case, the lesion is hyperechoic. It could be round or oval shape and is located in the subcutaneous tissue or hypodermis, and also follows the axis of the skin layers. In the image at the bottom on color Doppler, you can notice that the lesion can show some vascularity, but in some cases you cannot detect vascularity. A particular form of presentation of lipoma is the Sogglia Lipoma. And in this case, you can see a bump, usually in the frontal region, and this lipoma is located underneath the fascia or underneath the muscle, the epicranius muscle, and on top of the Moni margin. Why it is important to tell that this Sogglia Lipoma has this location? Because when this patient go to surgery, if the lipoma is located in the subgaleal region, the surgeon will not see the lipoma. So it is very important to describe the location. Another request for dermatologic ultrasound is vascular lesions. Vascular anomalies or vascular lesions, the most common ones, are hemangiomas of infancy and vascular malformations. First, some words about hemangiomas. Hemangiomas and vascular malformations are completely different. They have different pathophysiology, evolution, prognosis, and treatment, so it is very important to have a differentiation of these entities. Hemangiomas of infancy or infantile hemangiomas are the most common benign tumor of infancy, and they are true endothelial proliferations. First, they present a proliferative phase with a fast growth after birth. In this phase, they tend to be ill-defined and hypoechoic and highly hypervascular. Then we go to a partial regression phase where the hemangioma becomes more slow in its growth and present a mixed echogenicity. Also in this phase, the hemangioma is hypervascular. When the hemangioma goes to the total regression phase, there is a stop of the growth and its appearance is mostly hyperechoic and hypovascular. In this phase, the hemangioma can present lipodystrophy because there is a replacement of the vessels of the hemangioma by fibroadipose tissue. The key point in hemangiomas is their mass appearance. Here you have different hemangiomas, and look the difference between the proliferative phase in grayscale, where the hemangioma is mostly hypoechoic, and then how the hemangioma goes to partial involution or regression and then into total involution. Look the difference in the degree of vascularity in the different phases. This is an hemangioma of infancy in proliferative phase. Look on grayscale the hypoechoic lesion in the nasal tip. This hemangioma is involving the nasal cartilage on the left, presents a high hypervascularity, as you see here in the power Doppler and in the echoangio image and video. These hemangiomas can present high arterial vascularity and also venous flow. In some cases, you can also notice arteriovenous chants. This is another case of hemangiomas of infancy, and in this case, the hemangioma is involving the parotid gland. When the hemangioma involves deeper tissues and is in proliferative phase, it tends to be more well-defined in comparison with the most superficial hemangiomas. This is a case that is showing an hemangioma in partial regression phase. You can notice the heterogeneity of the lesion located in the dermis and hypodermis, and let's say a medium vascularity. Then an hemangioma in total regression phase, which is impossible to confirm with the clinical lesion. You can see here that the lesion is mostly hyperechoic and present a few vessels, mostly in the periphery. So, what is the role of ultrasound in hemangiomas of infancy? First, the detection of the involvement of deeper layers and monitoring the evolution or treatment. Second, the vascular malformations. These are not tumors. These are errors of morphogenesis, and they are composed of disproportionately high numbers of channels or nest of vessels. They tend to grow slowly and in a proportionate way over time. They can be classified in high flow and low flow. The high flow are the arterial and arteriovenous, and the low flow are the venous, lymphatic, and capillary. The high flow arterial vascular malformation, as you have here, present usually a high degree of blood flow on color Doppler or power Doppler, as you see here. This is an arterial vascular malformation, as you see by the pulse Doppler, with a very high vascularity. In this case, we have a low flow venous vascular malformation that is composed by lacunar and tubular anechoic structures that it doesn't present blood flow when you look on color Doppler. But if we put our spectral curve analysis, you can notice the venous flow. One tip to detect better these vascular malformations is to compress the lesion and see the venous reflux. Another vascular malformation is the lymphatic one. This is a low flow, and usually it appears as lacunar or tubular anechoic structures, and normally it doesn't show blood flow on color Doppler. This is a case. You can see the lacunar structures in the videos. And then you have the low flow capillary malformation that normally it doesn't show too much. In this case, you can see an hyperechogenicity of the subcutaneous tissue, but that's it in both segments in comparison with the normal region. But usually it doesn't show too much. What is the main role of ultrasound in vascular malformation? First, identify the type and extent of the vascular malformation. The second is to guide percutaneous procedure or sclerotherapy and monitor non-invasive treatments such as, for example, another application of ultrasound is skin cancer. I'm going to talk about the most common skin cancer in human beings, and this is the basal cell carcinoma. Basal cell carcinoma is not a little cancer. Usually the people don't die with the basal cell carcinoma, but it can be very disfigurating because it affects exposed to sun regions such as the face. In this article, we published that there is a high correlation of the thickness of the lesions between ultrasound and histology. Here you have an example. You can see the lesion is almost the same on ultrasound and histology. Very, very similar. How a basal cell carcinoma looks on ultrasound? It appears as an hypoechoic, usually dermal structure, but it can be deeper, of course, and it presents hyperechoic spots. These hyperechoic spots are almost pathognomonic of basal cell carcinoma because they are not present in a squamous cell carcinoma or melanoma. These lesions tend to be they tend to present low vascularity or a medium level of vascularity. In this article that we published in the European Journal of Ultrasound of Dermatology, we notice that the number of these hyperechoic spots these numbers are linked to the aggressiveness of the tumor. So, as you can see here, ultrasound can predict the presence of high risk of recurrence subtypes of basal cell carcinoma. The high risk of recurrences are, of course, more aggressive subtypes such as micronodular, morphiform, sclerosing, infiltrative, and metatypical. The cutoff point in this study was equal or higher than 7 hyperechoic spots. If we go up to 70 MHz, we can notice these hyperechoic spots more easily. Some of them correspond to calcification, some of them correspond to corneum cyst, and some of them we don't know. We suspect that these hyperechoic spots are also part of some molecular components because they don't correlate on histology with calcifications of corneum cyst. But what do we have to answer on the report? Normally the questions are, for example, in this case, is the auricular cartilage involved by the tumor? And as you see here, this is a transverse view in the ear pinna, and you can notice the lesion, hyperechoic lesion with hyperechoic spots. The lesion does not affect the cartilage that is at the bottom. You can see the hypervascularity of the tumor. And in this case, we have the same question. And in this case, the answer is yes. You can notice that the tumor, the hypoechoic tumor, that presents some hyperechoic spots, very few of them, because this is another type of basal cell carcinoma. This tumor is affecting the cartilage. And you can see that the cartilage becomes hyperechoic and ill-defined. In this case, you see a patient that presents a biopsy that says basal cell carcinoma with infiltration of the reticular dermis. The patient was treated with 3 sessions of cryotherapy, and it is not clear if the patient presents remaining basal cell carcinoma. So the patient was sent to ultrasound, and we performed the study with 80 MHz. And you can see the bump in the border with thickening and hypoechogenicity of the dermis. And if you go to 70 MHz, you can notice now the lesion with some hyperechoic spots. And in this case, we perform a cutaneous ultrasound marking of the lesion because the patient presented tumor on the borders of the lesion. Now we are going to talk something about inflammatory dermatologic conditions. And I'm going to talk about hidradenitis suppurativa. This is a chronic autoimmune disease that affects the hair follicles and generate abscesses and fistulous tract, also called tunnels, that run in the dermis and subcutaneous tissue. The most common location of these lesions are the axillary and groin regions, which are called intertriginous regions. In this article that was published in the journal Dermatologic Surgery, we performed a study on the clinical and ultrasonographic characteristics of these patients. And the conclusion was that the clinical scorings underestimated the severity of the disease. These results have been confirmed later by several groups of different countries. Also in the same article, we described the key lesions that compose the ultrasound criteria for diagnosing hidradenitis suppurativa. These criteria are confirmed by the widening of the hair follicles and the presence of pseudocystic hypoechoic structures, fluid collections, and fistulous tract that are connected to the dilated base of the hair follicles. Of course, there are also some inflammatory signs in the dermis, such as hypoechogenicity and thickening. Here you have a fluid collection on your left that appears as a sac-like structure, and then a fistulous tract on your right that present linear hyperechoic structures that corresponds to fragments of hair tracts. These fistulous tract or tunnel, as you wish to call, can be very long, and they can present different degrees of fibrosis and hypervascularity according to the degree of inflammation. On ultrasound, there is a scoring to state the severity of the disease that is published in the same article. We know that the intra-observer and inter-observer agreement using ultrasound in hidradenitis suppurativa is much better than the intra and inter-observer agreement of the clinical scorings. And this was proved in this multicentric study that was performed in 13 hospitals of Spain. If we go up to 70 megahertz, we can see with exquisite detail the early changes of hidradenitis. That includes, for example, the dilation of the hair follicle, the curve shaped, the ballooning of the hair follicles, and the presence of thick fragments of keratin in the dermis, and the different types of fragmentation of the keratin within the lesion, such as, for example, a multifragment type or a cylindrical type of fragmentation. We found that these multifragment and cylindrical types of fragmentation are associated to different types of lesions. So the importance of ultrasound in hidradenitis suppurativa is that after the ultrasound, there is a high modification of the treatment that goes up to 82% in adults and more than 9% in children. So there is a high impact of ultrasound in hidradenitis suppurativa because it can increase the accuracy of the diagnosis, support the early diagnosis, and of course, because of that, allow a modification of the treatment, and beside that, help the drug researchers. Then, some words about complications of fillers. So far, ultrasound is the only imaging modality that can discriminate the different types of cosmetic fillers. I mean the most common ones. They can be divided according to the echogenicity in anechoic and hyperechoic. Examples of anechoic fillers are, for example, hyaluronic acid. And then examples of hyperechoic fillers are silicone oil and, for example, polymethyl methacrylate or calcium hydroxyapatite. Here you have a patient with edema and erythema 1 month and a half after the hyaluronic acid injection in the tip of the nose, and you can see the filler pseudocystic anechoic structures in the subcutaneous tissue. This is an overfilling of the nose, and of course this tremendous amount of filler is causing inflammation in the periphery and in the nasal cartilage, as you see here, because you can notice the hypervascularity in the alar cartilage here. In this case, the patient was a male that denied an injection of filler and was sent by an ophthalmologist. The probable diagnosis was a vascular lesion, and the patient presented bulging eyelids for 1 year and a half with a bluish tone. And we performed the ultrasound, and this is a longitudinal view in the lower eyelid and upper part of the malar region. And notice the anechoic pseudocystic structures here, very suspicious of hyaluronic acid. And if we go to the 70 megahertz probe, there's no doubt that this is hyaluronic acid. And what we are seeing is called Tyndall effect, which is a bluish color caused by the reflection of the light when there are fillers, such as hyaluronic acid, in the region. So this patient was treated with hyaluronic acid and becomes better. Then we have a granulomatous reaction post-hyaluronic acid injection. You can notice the bump in the frontal region, and there were oval-shaped hypoechoic structures in the site of the injection of the hyaluronic acid. Other filler that is not uncommon, unfortunately, is the silicone oil. The silicone oil presents on ultrasound as hyperechoic deposits that produce a reverberation artifact, which is called a snowstorm. Usually when the patient said that was injected on the lips, we have to look for the whole face because normally they have more deposits. Even sometimes in the lymph nodes. Another filler is the calcium hydroxyapatite. You can see here a patient with bumps in the face, and notice that this filler presents as hyperechoic with a posterior acoustic shadowing artifact that is caused by the calcium in the filler. So when the filler is injected in a too superficial location, it can produce these bumps. Inflammation, of course. Lastly, some words about nail lesions. The most common request of nail ultrasound is glomus tumor. This is a tumor of the neuromyoarterial plexus. It is very painful, and you can see the clinical lesion in this case. It is producing an erythronychia, which is an erythematous band. Not all the time they produce this erythronychia. Sometimes they don't produce any alteration in the nail plate. But in this case, you can see a typical glomus tumor as an oval-shaped hypoechoic structure in the proximal part of the nail bed. However, they can be located, of course, in other parts. Notice that this tumor is producing an scalloping of the bony margin of the distal phalanx and is displacing upward the nail plate. On color Doppler, you can notice the hypervascularity of the tumor. Most of them are hypervascular, but not all of them. Some of them can be hypovascular. Another nail tumor that you can find is the onychoma trichoma. And this is a tumor derived from the nail matrix. Usually the tumor is eccentric and it involves the area of the matrix, and it is hypoechoic and presents hyperechoic line or spots that protrude into the nail plate region. These tumors tend to be hypovascular or present intermediate vascularity. Another lesion that could be studied in ultrasound is the Mixoid Cyst. And this cyst produces usually a lump in the proximal part of the periungual region. and it shows on ultrasound as an anechoic oval-shaped structure in the dermis. We had to find a connection of this cyst to the interphalangeal joint because in most of the cases there is a connection, a thin anechoic tract that is connected, and also there is a synovitis of the joint and osteoarthrosis as well. And another condition that you can find on the nail is retronychia. This is the posterior embedding of the nail plate. You can see here an acute retronychia with erythema of the periungual region and swelling. There are signs that are published in the literature to diagnose retronychia. One of them is the decreased distance between the origin of the nail plate and the base of the distal phalanx, as you see in the upper image, and also the presence of an halo, an hypoechoic halo, surrounding the origin of the nail plate and the thickening of the proximal nail fold. So, in conclusion, ultrasound can provide critical information about common dermatologic conditions. You have my email, the webpage on Skin Ultrasound, my Twitter and my Instagram, if you have interest to know more about this topic. Many thanks for your attendance to this lecture.
And now I am pleased to present Dr. Wartzman for live Q&A.
Thank you, everybody, to stay until the end. There's one question from Dr. Henry Song, and the question is, where in the body are epidermal cysts? And the answer is they could be everywhere. There are some regions that are more rare to present an epidermal cyst, such as, for example, the palms and soles. But still, you can have an epidermal cyst due to trauma. So they could be everywhere. Okay, I don't know if you have more questions. Please let me know in the Q&A chat, so I can answer. There is another question. Well, what tissue the hypoechoic spots are made? Okay, some of them are calcifications, some of them are conium cysts, but there are many that we still don't know. We suppose that these hypoechoic spots are molecular deposits because we cannot correlate them in the histological views. So there's still research that should be done to know more about these hypoechoic spots, but the importance is that these hypoechoic spots are not detectable in squamous cell carcinoma or in melanoma. So this is a good way to discriminate. Let me see. Well, there is a question about dermoid cyst. We didn't speak about dermoid cyst in the lecture, but the question is, it can be possible that dermoid cyst can invade the bone in the head. Invade the bone, I mean, as infiltrate, I haven't seen. I haven't seen it mentioned in the literature. Usually dermoid cyst appears as an oval shape or round subaponeurotic lesion that usually generates some scalloping of the bony margin. it is more common in the tail of the eyebrow. That is a very good location for dermoid cyst, but I haven't seen invasion of the bone. I don't know if there are more questions.
There are questions in the Q&A.
Okay, let's see. Do you guide injection with ultrasound? It is possible, yes. You can guide injection of fillers, for example, or hyaluronidase under ultrasound. There are publications that report that in the literature. And of course, it is very good because you are seeing the needle and the deposits. The other question is, do melanomas also show those white spots? The answer is no. That's why the hyperechoic spots are a very good sign in basal cell carcinoma. But the diagnosis is possible after pathological examination. That's another question. I don't understand that question. If the person, why are you using color flow Doppler more than pulse Doppler? Pulse Doppler is more sensitive than color flow for superficial structures. Yes, you're right. I didn't show too much pulse Doppler because we didn't have too much time. But the protocol is of dermatological ultrasound examination include the grayscale, the color Doppler, and the power of pulse Doppler for all the examinations. So if you look the literature, you will see that. I didn't show every image because we take a lot of images, but of course it is important to use the pulse Doppler and the power Doppler. The power Doppler for detecting more slow flow. This is more important in some machines than others. In some of them, the color Doppler is very similar to the power Doppler, but by definition, the power Doppler should be better. I don't know if we have more.
We have one more question in the Q&A.
Yeah. Okay, what kind of technique did you use to create the orange images? I don't understand the question. I don't know what the person. Can you clarify that? I don't know if the person could write something because I don't understand the orange images. Okay, let us know when you want. I don't know if we have more questions. I would be glad to answer. Otherwise, you can email me and contact me through the Twitter or Instagram, and I would be glad to answer. You have some images that are not grayscale. That's the question. Yes, we use grayscale, color Doppler, power Doppler. We use all the tools of ultrasound in these studies. I barely understand. I'm sorry if you can't understand me. I try to answer everything. There is another question in what. Oh, I understand now. Okay. The orange ones is the sepia ones that I showed. These are images with color filter that comes directly from the machine. There are some machines that come with these filters and you can use it. I use it because I like it. And I think this is a nice presentation. There is another question. The question is, I understand that we cannot use ultrasound for lesion. So in general, in which situation do you encourage ultrasound? Well, I think I mentioned the top applications, and these applications that I mentioned are really daily practice for me. So I encourage in all these cases to use dermatological ultrasound. How do you report? Well, the reports are, I report all the details that I mentioned, the diameters, if the lesion is solid and or cystic, the vascularity, the distance from the lesion to important structures. If there is, for example, skin cancer, I mentioned the involvement of deeper layers or deeper structures. So I think all the details, the flow, the color flow, and the power Doppler, if you're using power Doppler. I also report the thickness of the vessels and the peak systolic flow of the arterial vessels. I mean, this is the protocol that is published in the literature. Other question is, which vendor has this 70 megahertz probe? I don't know if I can say that, Ashley. I don't know.
No, unfortunately, we can't.
Okay, sorry. Have you ever used Contra enhanced ultrasound for skin lesions? No, I haven't used it. I know some experience from Dr. Marcio Bauer from Brazil on a camel cell carcinoma. It is published in the literature. But for us, really, we didn't try it because we didn't feel it was too much to give. Too much information for the daily practice. Another question is, hello, what are the main difference between Fibro Lipoma and the more aggressive ones? I mentioned two features on the lecture. One is this, normally Fibro Lipoma is homogeneous. So if you start to see the Fibro Lipoma with heterogeneity or hypervascularity, you should think about malignant transformation. Other features could be the diameter. It is published that more than 5 centimeters could be the diameter that could indicate some malignant transformation. I'm not so sure about it, but it is one of the things that have been published in the literature. I think I answered that question.
Yes, I don't see any more questions in the Q&A, so we'll go ahead and conclude today's webinar here. So thank you, Dr. Wartzman, and on behalf of the AIUM, our thanks to all of you who participated in this webinar. I'd like to remind you that a recording